So welcome today to our discussion. We're discussing vascular anomalies. Yes, so we'll start with the pretest.
Okay, let me take number one.
Wait, let me see if I can.
Which one of the following statements regarding hemangiomas is correct? A. They represent the most common tumor in infancy. B. They occur twice as often in males compared with females. C. 20% of hemangiomas occur in the head and neck region. D. All subtypes typically develop a few weeks after birth. E. Most patients have two or more concurrent lesions. I choose A.
Why didn't you go for D?
It can be all. Some of them appear from birth. Some of them appear. The infantile would appear after birth, but congenital can appear from birth. But they're the most
Okay,
common tumor in infancy.
okay,
Okay,
okay.
thank you for that.
Let me see if I can. Number two. A 3 months old infant is seen at clinic with an. Can you read for me, madam?
Yes, with an
Ngwane,
enlarging
please.
vascular lesion to the buttock. It began as a
Okay,
small spot shortly after birth and has grown to measure 1.5 cm diameter. There had been some episodes of bleeding following minor trauma, but it has been stable for the past 3 weeks. How best can this patient be managed? A. Propanolol, B. Steroid, C. Laser, D. Surgery, E. Observation.
oh.
The heading is Management of Hemangiomas.
Management of hemangioma. How old?
A 3-month-old infant
Okay,
is seen in enlarging vascular lesion to the buttock.
okay.
It is now 1.5 cm in diameter,
Mm-hmm.
bleeding following minor trauma, but has been
Okay.
stable past 3 weeks.
For me, I'll go for observation.
Okay, so that's E.
Yeah, I've thought of surgery. I thought it's one of the indications for surgery. Okay, well, when we do the post test, sure.
Okay, let me take number 3, clinical cause of hemangiomas. You are discussing long-term outcomes with a family of a 6-week-old infant with a 1 cm infantile hemangioma to the cheek. Which one of the following should you tell them? Involution is most likely to complete within a year. Involution is unlikely to occur without treatment. Further growth is unlikely. Involution occurs in 75 of cases by age 5. Involution may be incomplete and the infant may require surgery. So I'll choose E.
I agree with you totally.
Choose E. I think it's supposed to be 50% at 5 years. Agree? Not
Yeah.
75% at 5 years.
There is
Sure, but they also say that that thing overestimates the resolution of hemangiomas.
Okay. Okay, that
But I will still choose E with you, sure.
okay.
no.
I think
See,
most resolve by 3 to 4 years.
Mm. Yes, these other figures of it's like they are new figures. But that's what those okay, yes. These 4 years now they are new figures. The older figures are that 50, 70, 90 or so.
Yes.
Those are some things that some of our older guys know. Mm.
but those things are based on rule of 10.
Okay,
Yes, there is a rule. There is a research work. I forgot who published it. So it has
okay.
this rule of 10. At 1 year, hello.
Yes, we are with you.
At 1 month is 10%. As 2 months is this. That is how that rule is a rule.
Okay.
Yeah. Somebody did a work and was able to come up with that rule of 10. That
Okay.
is all of them 55 months of 97 months and all that.
Okay. Okay. Thank you. Let me move to number 4. Number 4.
Okay.
Okay.
For each of the following descriptions, select the most appropriate option. Each option may be used once, more than once, or not at all. Question A. This is the most common complication of a hemangioma. Most common complication of a hemangioma. Most common complication. Maybe I'll just take bleeding. H,
Okay.
but I'm not sure. Then B. This occurs when there is profound thrombocytopenia in conjunction with a hemangioma. That is Kasabach-Merit syndrome. Then C. A patient has retinal hemangiomas and hemangioblastomas of the cerebellum in conjunction with pancreatic cysts. Okay, I will take von Hippel-Lindau disease. That's C. So my answers are H, D, and C.
Okay, thank you for those.
What
Number
what happened to B?
B is
First syndrome.
posterior 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 fossa malformation, hemangiomas, arterial malformations,
Mm-hmm.
coarctation of the aorta, cardiac abnormalities, ear and eye abnormalities. So I'm not hearing anything about GIT. That's why.
That
Is
might
it?
just be a confusion.
I don't know, Sha. Okay, because of the cerebellum.
We have
It's possible.
cerebellum.
I
We
don't
have
know.
retina.
It's true. It's true. It's true. Okay, let me change. Let me copy your work, Chief. Face syndrome.
Okay, vascular malformation. That is 5. Which of the following statements is correct regarding vascular malformation? BA. They are not usually present at birth. They grow proportionately with the child and often regress. The autonomic nervous system has little influence on their development. They represent structural anomaly because of faulty embryonic morphogenesis. During embryonic development, capillaries develop from arterial and venous precursors. I will take D.
okay. Thank
Hello, I take
yes.
the D.
Okay, thank you. Let me take number 6. Port wine stains, capillary malformations. Which one of the following statement regarding port wine stain is correct? They affect 3 in 100 newborn babies. The neck is the most common anatomic location. They often correspond to the distribution of the facial nerve. They are more commonly observed in males. If left untreated, 70% will progress to a cobblestone ectasia. Okay, so I'm taking E.
Okay. Match each of the following descriptions of vascular anomaly to the most appropriate option. Each option may be used once, more than once, or not at all. Question A. This syndrome is characterized by microcephaly, multiple lipomas, and vascular malformations. I think I'll go with
Syndromes.
Banayan-Zonana syndrome. Question B. This syndrome includes an arteriovenous fistula, port wine stain, and venous lymphatic malformation in an extremity with associated skeletal hypertrophy. This is it Kipel-Trenoni?
Yes.
Yes,
Kipel-Trenoni syndrome. Then question C. This syndrome is characterized by multiple
Kliper.
malformed ectatic vessels in skin, mucous membrane, and viscera. Let me just take Osla-Weber-Rendu. I don't know that is the answer, Sha. So C.
So that A, what did you choose? That banana looping.
I chose that
Banaya Zonanana.
Banayan-Zonana syndrome.
Okay. Okay. Thank you. Number 8.
Okay, match each of the following description to the most appropriate option. Each option may be used once, more than once, or not at all. A. The condition is associated with patchy spot wine stain on an extremity and deeper venous and lymphatic malformation. I take E. Clapey-Toroni syndrome. This condition is characterized by large facial port wine stain with V1, V2 involvement and venous malformation of the pie matter and arachnoid matter. V1, V2. That should be
Sturgeon.
Sturge-Weber syndrome. This condition is associated with pseudo papilledema, microcephaly, and vascular malformation. This blue rubber bleb nervous syndrome. Not too sure of this. So I will take B.
Okay.
EDB.
Well, thank you. Number 9. Which one of the following statements is correct regarding venous malformation? A. They increase in size when elevated. B. They are treated successfully with area laser. C. They are usually painless. D. They tend to enlarge in puberty and pregnancy. E. They are no longer treated with sclerotherapy. So I'll take this D, that they enlarge in puberty and pregnancy. D.
Okay. I was thinking of C, but okay, when we do the post test, sha.
They are
Um,
painful. They have those phlebolytics because of stasis.
ah, okay,
Yes,
okay,
because of that stasis of venous congestion. Mm.
okay. Which one of the following statements is correct regarding lymphatic malformation? A. They have little effect on adjacent bone growth. So that's false. B. They rarely occur in combination with venous abnormalities. They could be combined now. Then C. They are commonly associated with clear cutaneous vesicles. D. They rarely become infected. E. Mobility is low after surgical resection. I think I'll take C. It's either B or C. I don't know.
Go for
I'll
C
take
now.
C. I'll take
Mm-hmm.
C.
I agree with you with that one.
Yes, that's number 10. Yes, I agree. So,
When managing arteriovenous malformation, which one of the following is correct? Although pulsatile, they are generally low flow lesions. Their vascular anatomy is best imaged using MRI. Embolization is indicated before surgical excision. Rates are low following complete excision. Consumptive coagulopathy is generally managed intraoperatively. I go for C.
okay. Thank you for that. So can we move over to the post test?
Yes, let's go, ma.
So number 1 is A. They represent the commonest tumor in infancy. We got that.
Okay.
And number 2, we didn't get it. This C, we chose C. The answer is E, observation.
Which one? Is
That it
observation we
comes.
choose now?
Oh, okay.
Is it not
Mhm.
observation you choose?
No, let me see what C was. C here is a. Okay, maybe I made a mistake. No, that is number 2. Okay,
Uh,
probably a mistake because C here is laser. I'm not sure we chose laser.
no, we didn't choose laser at all.
Okay, observation, fine. Okay, so that's my mistake. Then number 3, we got it E. Involution may be incomplete and the infant may require surgery. That's as what you cancel. We got that. So number
Yes,
4. Number 4, there are
we
3
fed it.
answers. We failed the first one.
Okay, the
That's D.
observation, bro.
Yes, but the other D we got it. And that's no the third one, we failed the third one. The
No,
third
no,
one.
that's what Alison choose first to before we comment.
Mm.
That von hyperlindua disease.
Mm-hmm.
I think that's what he choose first.
Okay.
I now was talking about the other one.
Okay.
So we fed it because everybody concurred to the other one.
Okay. That's the von Lindau disease. So that's the one that has pancreatic cyst with it.
Yes.
Okay.
Visceral cyst. Mm.
Visceral cyst. Okay. So then number 5, we got it D. They represent structural abnormalities because of faulty embryonic morphogenesis. Number 6, E, we got it. Number 6, we got it. Number 7, B, we chose B, E, and C. So is that the second one that we did not get?
Okay.
Aortic malformation,
Which one?
pain, venous malformation in the extremity with associated skeletal hypertrophy. So that's Parkes-Weber syndrome. So, but I have banana,
Okay.
banana. Banana Zunana was correct. Hmm. Okay, so this Osler-Wembarendu disease. Okay, multiple malformed ectatic vessels in the skin, mucous membrane, and viscera. Okay, so that's just it. Okay. So number 8, E is correct, D is correct, but the last one we chose B instead of A. That's
Okay.
and that's
Okay, really Smith syndrome.
Mm. Man, we have to write this syndrome somewhere and revise it so that it will stick to our brain. Mm.
Syndrome wey dey for plastic. If you carry all of them for your brain, you go die.
Like this topic is the one that most syndrome. This topic.
uh,
Mm. So number 10. Number 9 we got D. Number 10 we got it C. Number 11 we got it C. So oh yes.
we didn't
Overall,
do bad.
yes, overall we've done well. It's those parts that do have one syndrome or the other. That was where there was an issue. But at least we've seen our weakness. And can someone volunteer an outline for us to have a discussion of the topic?
I think one is we introduce under the introduction. Maybe we'll try to define. Then some epidemiology, if it's available, we'll add it. Then um, once you define epidemiology, you now go to classification. You now classify the pathology. Um, After classification, you now discuss the pathogenesis. The pathogenesis and now move to. After pathogenesis, you now talk about the etiology, if there is any. Like this one, I think it will be etiopathogenesis. You talk of clinical evaluation, which comprise the history, the investigation, the clinical examination, the investigation, which involves some imaging. Then I missed out something. I think under the classification, that is where you now talk about those that are associated with some syndromes. You now talk about maybe treatment options for different type. After pathogenesis and etiology, instead of evaluation, I think we'll bring the complication of the disease, not the complication of the surgery, the complication of the disease. After that, we can now talk of the clinical evaluation and now talk about the treatment, the different modalities available for the treatment. Then we'll talk about the complications of the treatment. Like this one, since it's pathology, you might not go into complication details. You only say briefly what you can offer. So I don't know. That is my own thoughts. Has, what do you think?
Thank you, Dr. Marshall.
I was asking
Thank
a
you,
question.
Chief.
Okay.
Okay, thank you, Chief Marshal. The only thing I wanted to add was I feel that since they specified pathology in the question, the pathology should be more prominent to some extent. So the epidemiology cannot be under the introduction. It should be separate. Like you should, if you're putting them under headings, introduction should be maybe definition and some introductory statement and statement of surgical importance. Then epidemiology should be on its own. And then if there's anything about the history of this particular stuff, it should also come up too. Then I think the prognosis should also be there.
Okay, thank you. I've added it to the outline. So, as we said, this pathology. Where are we putting the pathology? Because in this our outline, there's no after introduction with definition, epidemiology, history, as we mentioned, classification. The next thing we had was pathogenesis. We had etiopathogenesis. So that means after classification, we should talk about the pathology, right?
No, no, madam, the pathology in outline. Pathology starts from your introduction,
Okay.
assuming that from your introduction, those etiology, those clinical feature, those epidemiologies, all those things are pathology. You have not gone to treatment.
Okay.
To your clinical features,
Okay.
or so after clinical feature, when you start investigating and all that, you are now moving, transiting to treatment or
Management.
management.
Okay. 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 I get what you. I get.
Chief, I was thinking that there will be also be a section where, like the pathology now, they will now have the gross I don't know, is it gross? Then the other one will be like the micro, like microscopic and gross anatomy of, I don't know whether I would say anatomy, but like to describe what the lesion and then describe what you see if you look at it under a microscope or something like that. Since it's pathology.
Okay. Me, I don't know about that. The one about under microscopy. But when I was pathology, what I was thinking is that under this pathology now, we'll now start talking about them one by one, like the vascular tumor. What is it? The vascular malformation. What is it? You understand? We'll now go in there because early on, it was just classification we we're going to mention. You get, but we've not even talked about it. So that was what I was thinking in that pathology. But he has given it another dimension. Dr. Masha, what do you think about the microscopic?
No, that is histology. It's not all of them now. You can't go through all of them talking about their histology.
Mm.
That is when you are writing in exam or essay, for instance. The essence of this talking and writing. If you have your pathology, your classification, under your classification, that is where you even talk more. When you group them, in each of them, try to say their differences as you
Okay,
go
under
along.
classification. Okay.
Under yes, under your classification,
Okay.
you now go along and say their differences, and
Mm.
what they are looking for out is those common ones that we see. If you see them, will you know their differentials? Will you be able to manage it? Will you be able to identify that this is what actually is the problem? So you go
Okay.
into it like the two groups they have. Once you divide it, you say these things are fine in this one different, this one from this one different. It's a bullet point.
Okay.
It's not like you are writing the textbook itself.
Okay. Thank you. I think we can start the discussion. Mm. The introduction. Let me take the introduction. Vascular anomalies are conditions that occur as a result of abnormalities in vessel formation. It's an old. It's a condition that has been known for long, but the progress in this field has been is one that has been hampered by inaccurate terminologies. As we'll see later in the history, we'll see that the terminologies has caused some confusion. So that hampered progress in the field before subsequently unifying terminologies had been used. But there are two broad classifications: the vascular anomalies and then the vascular malformation. Sorry, the vascular tumors and the vascular malformation. All of them are broadly categorized as vascular anomalies. They are a source of, they have differences as we'll see. They're a source of concern and distress both to the parents and to the patient involved. That's when people come as adults. The treatment is multidisciplinary, involving the plastic surgeon. Depending on the type and where the lesion is, may need dermatologists, cardiovascular surgeons, especially for those AV malformations. Then we also have our nurses. We have the radiologist and the oncologist, because some of them are malignant. The treatment is multidisciplinary. So knowledge, adequate knowledge of the classification, which is the terminologies, appropriate terminologies, pathology, and then management will help us get good outcome and even counsel the parents appropriately when we meet patients with these conditions. Thank you. So that's the the introduction. That's the definition. I've mentioned the definition. I just added some other things. Okay, we're saying epidemiology should be separate. Eh? History is on that the introduction, or is on is separate.
He says
Doctor,
separate.
okay, history will be separate. Okay, so
He was saying separate.
okay, I've defined.
What I
Defined.
will only add to what you have said is multidisciplinary and multimodal.
Okay,
And that's just what I'll add. I think you did very well in the introduction.
okay,
Okay, let me say something in the etymology. Um,
Chief, sorry, can I take the history first?
okay, okay.
Okay, so Virchow was the first to propose a classification system for vascular anomalies in the 1800s. And after that, Mi, is it Milliken and Glowacki came up with their own classification in about 1982, where it was based on the vessel type that is found, whether it's lymphatic, arterial, venous, capillary, or a combination of both. Then in 1996, the International Society for the Study of Vascular Anomalies also proposed a new classification, which was heavily based on the work of Milliken and Glowacki. But as at 2014, a new classification was put forward that divided them into the classification that will come up shortly. This was what I got from, I think, both, what's the name of that book now? Grab and Smith and Essential. Thank you.
Okay. Uh, I think, anyway, maybe when we go into the classification, because what sorry, what I used to know or what I looked at, what I saw, is that that work by Milliken and Glowak was the key 1982, was able to divide it into two, tumors and malformations. And that was what the International Society for the Study of Vascular Anomaly adopted, I think, in 208 or thereabouts. Anyway,
Chief, it's
when we
still
get
similar
there.
to what I said. As
yeah,
in,
Uh,
yes, the work of Milliken and Glowacki heavily
yeah.
influenced the classification, but it's not like I've not seen the separate classification, so, but they made it look like
Uh,
they did not just accept it as they did it, but they used a lot of
okay.
what they did to make the
Okay.
classification. Yes.
Okay. 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 Okay.
uh,
Vascular anomaly. Okay. Sorry.
yes, I want to add. So before the virtue said it, initially there was that you hear things about maternal folk tales. They talked about what the mother ate. If the mother ate strawberry most, the mother will have the baby strawberry hemangiomas. Yes, in the history, here's one funny history. If she saw bigger things, then she will have one other thing. So that's why initially they're talking. It was related to the food that the mother
Uh,
ate, and they said if the
yeah.
mother her period, if she conceived during when she was seeing her period, the child will have. Is it that the child will have which of them? The okay, that is the pot wine. The one that is taking the strawberry is the mother that is
Uh,
eating a lot of strawberries. Do you get? So we had all those
uh,
folk tales before Virtual now tried to put his own angioma simplex, multiplex, and then cavernosum. Before later, we now had Reinhoff and all this. I just want to add that there's the most recent, the last time I saw there's a 2018 modification of the classification. And
ah,
as we said, that international society they actually adopted the work of Milikin and Glowacki. And
yeah.
yes, before now they are now updating, but that was the main thing that they used. Yes, it was adopted. So they adopted that classification, but later they now started dividing. Now you see we have benign, borderline, malignant. It wasn't like that before. Mm. Okay, thank you. That's just my addition to this.
Okay. Vascular anomaly is one of the common childhood vascular pathology that affects various locations and occasionally um, involve some of the viscera. However, the tumors, especially hemangiomas, are common in the Caucasians, are more common in female to the ratio of 3 is to 1. Why the vascular anomaly malformations don't really have sex predilation or race. Okay, no predilation to race or sex. They have equal sex distribution. Infantile hemangioma accounts about 60 to 70% of the tumors. I beg somebody should pick up. That is what I can remember.
Okay, that's the epidemiology.
Epidemiology, yes. I think there's something I'm forgotten
Okay.
in the
I see
percentage.
how epidemiology for them is just the site. Most of the ones I see that when they are talking about site, they now start
Uh,
with uh,
the
head and
head
neck.
and neck,
The,
yes, accounts about 70% of most of them, the common site, yes. Okay, that one is not epidemiology.
mm,
It's just a red herring stuff. No,
okay.
that is all. I beg.
Thank
There's
you.
not much in the epidemiology.
Okay. Thank you. I think the individual epidemiology, when we go to them one by one, because yes, okay, the timing of occurrence is actually a clinical feature, not an
Yeah.
epidemiology. Yes. Okay, thank you. Then those other risk factors. Dr. Allison, do you have anything to add?
Okay. I think part of the reason I saw for epidemiology is that they said hemangiomas are the commonest tumors of infancy. Um, I think they said 11 can be found in 10 infants or something like that. I saw that one in Grab and Smith.
Okay, 11 in 10 infants. One
Yes.
infant, one than one. Okay.
It was very funny when I saw it. That's what I remember.
Thank you. So move over to the classification. So the classification, as we mentioned, vascular anomalies are broadly classified as vascular tumors. And the vascular tumor has abnormal endothelial hyperplasia, while the malformation is defective formation of the vessel wall during embryogenesis. So those are the two broad classification. The vascular tumor is broadly divided as we have the benign, the borderline, and the malignant. So for the vascular tumor, let me go back again. We have benign, borderline, and malignant. That's for vascular tumor. So examples of the benign is the infantile, the congenital. Then we have things like pyogenic granuloma and tufted angioma. That's under benign. You have the infantile congenital pyogenic granuloma. Under borderline, we have things like Kaposi sarcoma, and there is this other Kaposiform endothelioma. It's under borderline. Then under malignant, these are our this angiosarcoma, those ones from lymphatics, like that Stewart-Trevor syndrome is a malignant form of that we can have from long-standing lymphedema. So angiosarcoma, then epithelioid hemangioendothelioma is an example of the malignant type. So those are the for the vascular tumors. Those are the three broad groups. Then for the vascular malformation was divided as is classified as simple. This one is 2018. So the we have divided as simple. That is if you have just one. So under the simple vascular malformation, could be just capillary alone, venous malformation, lymphatic malformation, or arteriovenous malformation or AV fistula. So that's for the simple. Then we have combined. Combined could be the capillary and lymphatic, or when we have capillary, lymphatic, as well as venous malformation, or when we have all. So we have simple, combined, then there's one those of large vessel origin, and then those that are associated with other anomalies, for instance, Dodge-Weber syndrome, Parkes-Weber syndrome. So that's the classification for it. So, Doctor, you said we should talk about them one by one after we classify. Eh?
Mm.
Okay. So, one thing we know about both of them is that apart from the incidents as we've mentioned, for the infantile hemangioma now is the one that has a classical history. Has it has the proliferative phase, involuting phase, and involuted phase. Those ones are characterized by the involute. They are up they occur after birth, just a few infantile hemangioma. They occur after birth, but some individuals may have some spots, some hairy lesions. And then they follow this progressive history. That's for the infantile hemangioma, which is the commonest of all under the vascular tumors. Then, but for the vascular malformation, those ones are seen those ones are seen at birth and they grow in proportion with the age of the child and they do not regress. Unlike the classical infantile hemangioma that regress, for the vascular malformation, they don't regress and the recurrence is something that is very common among them. So let me just talk about them a little about them one by one, though it's wide. So for the infantile hemangioma, I've already mentioned that it's commoner in females than males and all those, and then we've mentioned the classical history. So they are commoner in the head and neck, and then they have that history of the commoner in the head and neck. They pass through the three phases. They are seen after birth, as I've already mentioned, and then they have a rapid growth phase, the proliferative phase. And that proliferative phase occur in the first year of life. I saw 0 to 4 years, the proliferative phase, where they grow rapidly in size. And then the involuting phase, I saw from 1 to 4 years of age. At that point, in the that proliferative phase, they are pink, and then the involuting phase, they start becoming pale, and the involuted phase, either they disappear or may now have small they may leave some fibrofatty excesses at that site, or the skin excess skin sometime, and some telangiectasia that we may need to do some other things for. And then most of the time for those infantile hemangioma, because we know this history, observation, okay, because of this history, but there are some that may occur in some places. There are some that may cause life-threatening features. For instance, those that are close to the eye, or they may cause some cosmetic abnormalities. The life-threatening ones are those that are in the submandibular region that may cause, that's the subglottic region, that may cause airway problems. If it is in the eye, it may cause this amblyopia. May, if it affects the ear, for instance, and the nose, those ones are in cosmetically sensitive areas that you don't want them to cause destruction. So those may be indications for early intervention. If not, most of the time we manage them non-operatively. So that's just to mention something about the infantile hemangioma. Then the congenital hemangioma. The thing about the congenital hemangioma is that they are fully formed at birth. So the sub-classification of the congenital hemangioma, we have the rapidly involuting congenital hemangioma, which is rich. Then we have the partially involuting congenital hemangioma, and then the non-involuting. So that 2018 also added this partially involuting, because formerly we just have the rich and the niche. So the rapidly involuting, they are fully formed at birth, and within the first year, they regress. There are some tiny, those other how they appear and all those halo and all those. I may not be able to mention it correctly. I forgot to mention that the infantile hemangioma is more common in preterm babies. That's a risk factors. Preterm low birth weight babies. So the rapidly involuting, so those ones they disappear within 7 to 14 months. Then the partially involuting ones, within the first year, they start reducing in size and then they stop. Then the non-involuting are well formed and they don't regress in size, so they are just there. So the management of the partially involuting and the non-involuting is the same sort of, you get. So that is it for it. Then for the Kaposi sarcoma, the pyogenic granuloma is an example there for also for that benign one. For the second one is the borderline. I mentioned the example of borderline is Kaposi sarcoma. As we know, Kaposi sarcoma is a vascular tumor associated with herpes simplex virus 8 and even HIV. So there are different types of Kaposi sarcoma. We have the endemic type, the classical type, the iatrogenic type, and then the HIV associated. So most of the time they are positive for the herpes simplex virus 8. And then if it is the HIV associated, they'll have HIV too, the positive. But they are malignancy that are seen in adults, not really in children. You get. So most of the time, and the extremity is what is commonly affected. You may have plaques and then the nodules. So the third one I mentioned, the example under the malignant type is the angiosarcoma. They are seen in patients that have so they are aggressive endothelial malignancies. And then most of the time, the risk factors are people that have long-standing condition like lymphedema. I was mentioning that Stewart-Stevens syndrome from long-standing lymphedema, or it could be those that have had radiotherapy before. But they are more in all adults too, and they metastasize mainly to the lungs frequently. So they are the malignant types of the vascular tumor. So those are the things about the vascular tumor, the benign, the borderline, and the malignant. So I'll go to the the vascular malformation. I've already mentioned that they are seen at birth growing proportion. So I'll just mention some unique things about the capillary. Sorry, I scratched that. I forgot also to mention that infantile hemangioma, it could just be, is it called superficial and deep, where just the skin. But sometimes, especially the congenital hemangioma, sometimes they can even have the hepatic ones. You may have the deeper ones affecting other organs, like it could be solitary. Most of the time it is solitary, but it could be multiple. Thing is, I saw that about 80% is solitary. Then other times it could be multiple. You could have that once you have the hepatic hemangioma, those ones may have high output cardiac failure. So I forgot to mention that, and it could be superficial or deep. There's something about that too. I forgot to mention. And then there was this thing again I forgot to mention. For the infantile hemangioma, they are positive for GLUT1, the glucose transporter 1, because they said they occur due to clonal proliferation of hemangioma stem cell that express that glucose transporter 1. So if we want to differentiate the infantile hemangioma from the congenital hemangioma, the infantile hemangioma will be positive for that GLUT1, the congenital will be will be negative for GLUT1. The others we've already mentioned HIV and co, depending on what we are talking about. I think those are some things I forgot. So the other one now is the capillary for the vascular malformations. Should I continue? I should hold on so that we'll talk about the tumors before we move to that malformation. It's now looking very long. Doctor, maybe I should hold on here. Doctor,
Oh, please go ahead. Oh.
no, Doctor Masha, what do you think?
You are doing well now. We are following. Any associated syndromes on the tumors?
It's true. So it's true. So we can add that for the tumors, the syndromes, those syndromes, I'm not so good with all those syndromes. So, uh, but yes, the you can't people can help me with those syndromes, I beg.
I
Because
Okay,
only
so
note
there are some syndromes there actually. I can't remember them. I have to go and commit those ones to memory because there are syndromes everywhere.
okay, for the syndromes, the ones associated with hemangiomas is the Kasabak-Merit syndrome. Then the faces, that's the PHACES.
Mm.
Then Mafuchi syndrome and von Hippel-Landau. I might not be able to remember the things that are ordered.
Yeah, okay. I'll have
Uh,
to go
s-
and
s-
try and see the way they use it to bamboozle us in MCQ.
Sorry, check that thing very well. Some text miss that thing up. The Marfus syndrome and Kansbach merit are associated with venous malformation. Those
No,
two.
that okay. Anyway, this cassava. Okay, you said
Uh,
because that cassava merit, you can even have
uh,
it here. Thrombocytopenia now. You can
yes.
that caposiform hemangioma. That's one of
Uh,
their application. If you read it,
association. Yes.
yeah, yes, that cassava merit. In fact, yes. So I think it's here too. In fact, maybe in all of them you get. So
Well,
we have to,
uh, okay.
yes, is in this that caposiform hemangioma. You know, it's a borderline type.
Mm,
Borderline. One of the texts you
it's
see
in
one.
between.
Yes, you see one baby with one red lesion. Which of is it Grab and Smith? Where was that lesion? Is it on the truck or the back? So you know that there's really trapped blood within it. Yes,
Mm.
so well, cassava merit is
Like
in
the cassava merit is more of thrombocytopenia,
yes,
bleeding, and petechia.
yes.
Then specific to
It's not
hemangioma
a, no, it's not a yes, it's not a syndrome per se. It's called
is a phenomenon.
yeah, sort of yes.
Specific to hemangioma is Pavey syndrome and Face syndrome.
Wait, what did you say first? You say waiting basis.
Pavey's.
Okay.
Then there's this Cope syndrome. I don't know very well about that, but to an extent sure of Pavey's and Face syndromes. Those two.
Can you decode
The
the pelvic?
the Pavey's is perianal hemangioma. It's more like a segmental perianal hemangioma. While the E is external genitalia abnormality. The L is leptomyomeningocele, while the V is viscorenal abnormality. The I is imperforate anus, and the S is skin tag.
Okay, thank you.
Okay, thank you, Chief.
Well done, sir.
Okay, then some of the ones that are associated with capillary malformations is the Sturge Weber that is seen in distribution of V1, V2.
Yes.
Yes,
Then leptomeningeal capillary malformations,
yes.
ocular symptoms and developmental delays.
That is
Then
choroidal abnormalities.
there is Kipel-Trenoni syndrome. That one has
Yes.
lymphatic malformations, hypertrophy of the extremity, usually the lower limb, then capillary
Uh,
malformation.
it's a combination.
Yes, of capillary, venous, and lymphatic.
Lymphatic, yes.
So I saw
Mm.
somewhere telling us that that lymphatic is associated with underlying bony, hyper,
Deformities.
yes, yeah, hypertrophy. Yes.
Okay.
Yes.
Then there's the Pax Weber. I can't remember what's on that Pax Weber.
Yes, there's Sturge Weber and there's Parkis Weber. That's
Then
Weber.
there is COP syndrome. COP syndrome is under capillary malformation.
Mm,
There's capillary malformation of the trunk, then spinal arteriovenous malformation.
Okay.
okay. That Parkis Weber, capillary malformation, AV malformation, and extremity overgrowth.
Okay.
Okay.
Mm. Okay, so let me just scratch the vascular malformations. The capillary malformations is abnormalities of the capillaries. There's something we forgot to. We forgot to discuss embryology. I'm just remembering. Just
Yes,
a,
so
I'm just remembering.
just few lines now. You won't go detail.
Okay. What I saw though, I was looking for a better stuff. But what I saw
Uh,
is that capillaries will appear first, and then subsequently we have the other vessels. There's the artery and veins occurring by their side at the
mm,
46 day. Yes, and the nerves have there's a relationship between the nerves and then so that's why sometimes when you have this vascular malformation, you may also have a nerve anomaly too. So that's just
okay.
what I saw. For the lymphatics, the lymphatics, but for that lymphatic malformation, sometimes you just have a nest of lymphatics that are not connected to the main circulation, and they just branch off at different sites. So that's why they continue to grow and secrete, but they don't empty. You get compared to the so that's at sites where you have it, they are cut off from the
Okay.
infection. Yes. So that's what I thought somebody even saw something. Tell us. Okay,
Seriously,
so
I didn't. Okay. Go ahead, ma.
yes. So for the capillary malformation, so there are abnormalities of the capillary. They are pink and they are in the skin. So sometimes they may give us this cobblestone appearance, especially when they are not cobblestone appearance, and they are the ones that they are segmental and may occur along the nerve distribution. It was when I saw this nerve distribution, I remembered in biology. Yes, especially as seen in the Sturge-Weber syndrome, where they may be seen in the V1 and V2. And it's like when they are there, they may have the individual may have an ocular anomaly too, right? So they may be there, and then sometimes they may herald underlying spinal malformation. For instance, when you see that patch, a spinal bifida, when you see that patch at the back, they may just be a herald spot to show. We've already mentioned that all this malformation will be present at birth and they grow in proportion to the size of the child. So that's what I have for the capillary malformation. Then for the malformation, they are due to abnormalities of the walls of the veins. The muscles, the muscle of the muscle is malformed, and then the valves too. But remember, so it's due to abnormalities of the veins. They classically they increase in size with dependency and non-valsalva maneuver, while they reduce when you elevate them. They reduce with elevation. So they're very soft and compressible. So I mentioned that because of the stasis in the vessel wall, can have phleboliths within the vessel wall. So those phleboliths are thickened, and the patient can have pain. Those phleboliths are painful. They can have localized intravascular coagulation because of these same problems too. So, but usually you see it as abnormal dilated vessel, like a bag of worm under the skin. When we see that part, it's warm. So yes, but so that's it about the venous malformation. Then the lymphatic malformation, also abnormality of the lymphatics, and we say that is when the lymphatics form at aberrant sites or they pinch off from the main lymphatic circulation. So when it is cut off, it will just be there on its own. So it may be macrocystic when the cysts are more than 2 centimeters in diameter, or microcystic when it is less than 2 centimeters, let's say 1 to 2 centimeters in diameter, or mixed. You know that this thing has a bearing on the management. Those macrocystic, we can do sclerotherapy for them, or unlike the microcystic, you understand. So it could most of the time is the head and neck that is commonest, but it can be other sites. The difference between this one, the venous malformation, we said it will increase with gravity. No, it will if you in the dependent position it will increase, and on vascular maneuver. These ones will not increase with dependency or vascular maneuver, and you cannot compress them. The venous malformation, you can empty it. This one are not compressible and empty, but they are also soft. And then something about them is that they talk about infection and those cutaneous vesicles that you can see around them. They are more prone to infections and even recurrence. Sometimes when you're operating around the head and neck, to even go and look for the root because of those important structures there. Most of the time, people don't follow everything down to it. So that's the what I know about the lymphatic malformation. Then for the arteriovenous malformation, where they occur where there's abnormal communication between the artery and the vein, abnormal communication. They are fast flow because of that arterial component. All these other ones are slow flow lesions, but once there's an arterial component, it is fast flow, and then it is pulsatile and warm at that site. There may even be overgrowth at that site. There's one staging system for arterial AV malformation. Is this Scobinja staging system, where you can have it
Okay.
initially, yes, at the crescent stage, where it is just there pink, and then you now have the expansion stage. Now you now be feeling thrills and all those at that site. Then we now have the destruction, is in a destructive phase. You are now having ulceration, bleeding, and then the other one is the compensation when they now have heart failure or something like that. So that is it about the. So these are the ones that have three. Then the other one will not have. The others will not have. Then we mentioned that it could be. We said it could be simple. It could be combined. Then we have those of large vessel origin and those with associated conditions. So Dr. Addison had already mentioned some of those combined with their, he had mentioned those ones with the syndrome. He had mentioned the Sturge-Weber, Klippel now. One of our chiefs said that they brought one child during a long case that had limb overgrowth. So it was when we were now discussing this and now it now made sense. I think the child had even with the limb was bigger and now had venous capillary. So it's actually Peltrinawi syndrome the individual had that they brought for him in part two exam when he went to Ghana. Mm. So I finished though. In case of additions, other ways that we can remember it easily.
Okay. Sorry. I think the old stuff is also helps where the especially the vascular malformation when you classify it low flow and high flow as you said, it
Okay.
gives easy yeah, it makes you remember a lot and you can easily group them fast, especially those that involves the artery
Yes.
are always high flow as you said. Then the phases for infantile hemangioma, I think is four. You have the proliferative phase, then you have the plateau phase before the invulating and before the invulated phase. Because at a point, it stages out. It doesn't increase, it doesn't decrease, it doesn't decrease. Then for some times, it starts invulating. After that, it gets to the invulated stage.
So this plateau phase is from when,
Mm.
what time do we attach to it? What timeline?
Uh, uh, Seriously, they don't really have a timeline per se. They try to give.
Mm.
They say the first uh, after 2 weeks, you are is likely to appear between 2 weeks and 1 month. Then within that period, the first 3 months, there is a rapid growth. Then within the first 1 month, which is about fourth month or fifth month, there is some level of stability. Then evolution takes off from 6 and 7 months.
Okay, Chief, thank you for that. But the one in Essential was slightly different.
Okay.
So they gave the nascent period, so the first
Okay.
few weeks of life.
Mm-hmm.
They talked about seeing a herald spot. I don't know, maybe it starts as a small spot first, then it starts proliferating laterally. So
Okay.
the next is now early proliferative phase. We gave a timeline of 1 to 5 months. Then
Okay.
the phase after that is the late proliferative phase, 5 to 9 months. But I can't remember the difference between those two phases. Then
Okay.
after that is the plateau phase. That's 6 to 15 months.
Okay.
So then the color will be dull purple and the lesion is still growing with the child. Then the involution phase is 9 to 15 months.
Okay.
So that was the timing that we gave in essential.
The phases now, as we said, we can take it that way based on what, but I think the key thing we have established just from what Alison also said, that nascent period before it manifests, which they say is between 2 weeks of birth to 1 month. Then those plateau, even if we don't know the time lag, you're able to know the phases. I don't think you should be crucified. But if you know it, since most of the books are not agreeing with particular time,
And yes.
so the most important thing is now to know that these phases are important. We'll be sure to have it. Then there is this, is it parasitic steal phenomenon in AVA malformation that leads to um, what do you call it? Is it high output heart failure?
Okay.
So it's important to mention it in arteriovenous malformation because
Mm.
that's why you need to embolize before you reset so that you have a control over it. Then there is there's something I'm forgetting. I don't know whether it's on hemangioma where it talks about their components. Um, hypotension. I don't know. I don't know what syndrome is that. Do you remember? There is hypertension, hypotension. There is hyperthyroidism. There is about three, four components. I'm just trying to. If I remember, I'll talk about it.
Okay.
If I remember, I'll talk about it. I'm just trying to search my brain about that. Then I
Mm.
think you have you actually did justice to it. Okay, yes, uh, Mafuchi syndrome that we talked about.
Yes.
I think is uh, echondroma and
Multiple
exostosis. Then
electron.
multiple echondroma and exostosis. Then I think is it hemangioma or capillary? I can't remember
Hemangioma.
again. Hemangioma, yes.
It's
I,
hemangioma.
is okay. I think that's what I was trying to remember.
Okay.
So, madam, we can progress now, huh?
Yes, sir. And so we're done with that.
Okay.
So
Sorry,
this
let me just add something to that stuff that you said about the, as in doing the surgery immediately after embolization. So I
Okay.
think in this essential as well, they added that you should do it within 3 days, as in within 72 hours
Yes.
of doing
Yes.
the embolization.
Yes.
Okay, thank you.
Thank you.
thank you. Doctor, the next thing on our outline after classification is etiopathogenesis.
The sorry, why I added this is something that we can actually, if you go through the books, there is no clear cut
Mm.
on the etiology. These are malformations that so many genes which have not been really isolated that are involved. So the etiopathogenesis, like the risk factor you talked about in hemangioma,
Yes.
premature is more common in premature babies. They're more common in
Mm.
female, yeah. So those things you can now see a way of adding them up to talk about it, because in the books I didn't really see anywhere they talk about it. So if it's difficult for us to arrange things and put in there, we can just skip it.
You
But in
know
the
that for
uh,
the infant hemangioma, I remember we were talking about the that is due to clonal proliferation of hemangioma
yeah,
stem.
okay,
And then for the for those venous malformation, there's something about puberty and pregnancy that they grew. There's some hormonal influence in the growth.
okay.
Then for lymphatic malformation, there are some genes for the lymphatic malformations. There's some
That is
there's
fibroblast growth factors receptor.
okay for that. And then there's this they say mutation of PIK and 3CA.
Yeah, PLK3 something. Yes. There are two
So
of them. Those ones that have that overgrowth, the two of them have it.
okay, fine. So those genetics, so
But
we'll put it as
sorry,
genetics.
when you get this textbook I'm sending, this third
Yeah,
edition of
Uh,
Essential,
uh,
there's a section where they will put almost all the associated syndromes, though they lumped both the hemangiomas and the what's the other one, the malformations together.
together,
But
okay.
at the end, yes, at the end, those of them that have these genes, like this PIK3, whatever, they put
yeah.
the
Mm,
genes there. So you
okay,
see them in the
okay,
table. Yes.
okay.
I'm already sending it, you'll soon get it.
Okay, thank
No
you.
wahala.
Mm. So remember, we also talked about prematurity.
Okay.
So we'll take note. So we'll put them. So that
Because
means we are going to, if we are going to do it, then we are now, if we are going to do it this way, we'll
mm,
not mention it when we are discussing them. Since we are going
yeah,
to separately, yes, so that it will not be repetition. Mm.
okay, okay. I think most of those genes are more common with vascular malformation
Okay.
than the tumors.
Yes.
I'll need to check to be able to say anything, sure, because I can't remember them.
Yes.
Okay.
They are more with the malformations. Yes,
Yes.
than the tumors. So there are some mutations, even in
Okay.
venous malformation. Yes, there are. Mm.
So, madam, let's progress because the most of the past questions, I think the pictorial and all that is more on the treatment.
Okay, so we can move over to and there's complication of disease before clinical
Yes.
evaluation. And we
Yes.
can move over to the complication of the disease.
I think we have almost said it now. Complication of the disease. Some can bleed.
No, that's
They can also.
the commonest.
Is there?
Sorry,
I
the
said
community is ulceration.
okay.
So I failed that one in the MCQ.
You don't go search am already. Okay.
I have to check it also.
Okay. Ulceration, bleeding, the disfigurement, uh, psychological depression, infection. They can get infected. Then, apart from okay, disfigurement is there. Then, um, when the limbs are involved, there's associated
High
abnormalities of
atrophic
the knee.
bacteria.
Then, heart failure. just like you said.
Yes,
Heart
I
failure is
am
just a
too.
uh, so I've mentioned like how many now? Seven now. Is Madam with us?
I think it's six. But I,
Yes, I'm with you.
Huh?
Yes, I'm with you. I just
We,
stepped out to do.
we
she's
said
there.
us,
She's there.
we said
Also,
ulceration,
mm,
bleeding, infection, high output cardiac heart failure, disfigurement, uh, psychological depression, and what's the last one?
No,
Allison.
last one I saw was multiple neonatal hemangiomatosis.
as
Okay.
complication.
No, it's not.
Yes, they
Is
put it
that
in that essential.
no? That is
Mm,
They said mortality in infants. They said
no.
mortality in infants with multiple neonatal hemangiomatosis is 54%. But they put it under complications just like that.
okay, so
Ah,
means have
Maybe
it.
when we are writing, we will just put it as maybe death or something else. I don't know because
Yes, yes.
this condition
bec-
is the only place where I saw it. I don't know why they do that.
ah. Anyway, where I saw it is when they were talking about investigations. It depends on size. Like they
Okay.
said, if you have segmental or much large uh, hemangioma greater than 5, you must investigate the liver. You must do an ultrasound or MRI to look at hemangioma because it's associated with the liver hemangioma. Then when you have small hemangiomas that are multiple, they call it, is it miliary hemangiomatosis? I don't know if you saw something like that.
No, I didn't come across that one.
Yes, I saw
Uh,
it.
you saw
Mm.
something like that, but,
Yeah.
so that in those two, you must rule out liver pathology,
Mm.
and the mortality is almost 40 or 60% in is it infant or early teens? I don't know. Can't remember again. So, madam, let's progress now. So I will go. You know, you have our outline. We are done with the complication.
Yes, we are going to clinical evaluation now. Clinical
Uh-huh.
evaluation. Move over.
Okay. The history. One, you want to know the gender of the child or the adult that is presenting. You want to know the birth history, and you also want to know when they notice it. Is it after birth or at birth? So this will tell you likely where what it is. Then the location is also important. You need to know the location, the site in your history. Then you also need to know if there is other associated lesions in the body. Then family history is also important of similar illness if there are siblings already. Even the parents, you want to know if at their birth they were told if they have similar problem. Then you now look at if it has ulcerated, history of bleeding. Then you also need to know in terms of complication, you want to know hypotension if it's there. Those that have associated liver pathology, they also have hyperthyroidism. You need to find out those things. Um, um, uh, the history also, you need to look at the developmental milestone of the child. Um, Then you also need to know if the lesion is also increasing as the child grows, or is just static, or is rapidly increasing in disproportionate to the size growth. Um, then what do you look for in the history again? I think for history, that's what I'll ask. Then on the examination, you you want to look at the location, and you want to know, you look at the color, and the color will give it away to an extent, and the location. For capillary, for hemangiomas, they are red, but with time they tend to get darker also. But for venous, they have this bluish or purplish color beneath it. Then it also depends if it's superficial or deep also. Then in your palpation, the hemangiomas or the tumors feel more firm and they don't empty. But some of the vascular anomalies, they empty, and you allow time, they refill back, especially arteriovenous fistula or arteriovenous malformations. So then if you auscultate, you can feel a brew. Then if it's large enough, if you place a hand on it and you tap, you can feel a tree. Mm. Then because of associated syndromes that we have talked about, you have to examine other parts of the body to rule out their involvement, especially in hemangioma when you have multiples. You need to look at for that. Then when you also have segmental port wine or salmon patch, these ones you also need to look out for associated syndromes, because then the ones that involve um, the trigeminal nerve 1 and 2 also, you look out for other associated syndromes as we have talked before and see if they are there. Um, then you basically, the diagnosis is clinical. From your history and clinical examination, you will be able to make your diagnosis. But if there is telltale signs of those syndromes, then necessary investigations that can be done are MRI, CT to evaluate the presence of this. You can do MRA also, and geography, MRI and geography also it can be done to evaluate some of these things, those syndromes. Um, what else again? Then our radiograph is also radiological investigation like X-ray is also important, like the malformation syndrome that we talked about. Those exostosis can be seen on X-ray if you suspect any. Then we'll now do our blood workup for the patient. I think I'm done. Please add flesh to it.
Thank you, Dr. Marshall. I just want to add that in the history, that history of a reduction in the size when the hand is
Okay.
carried up or when it is put down, increase in size, we also add that. We want to ask
Okay.
for history of care too, because it will help us to know what has been done, what other step do we need to do, especially
Yes.
those ones that had some treatment, whether we are going to second line therapy. Yes, then you've mentioned family history and even complications of, we'll take history of complications too. For the examination, comorbidities, like all those people that have HIV, it will guide us. Remember that the topic is a little broader than what we used to think. So we take note of all those. May help
Yeah.
us to get a diagnosis. Yes, so I think that's what I want to mention. As part of the investigations, chest X-ray would reveal phlebolytics. Then the MRI, you
Yeah.
already mentioned the MRI. That MRI will show the high flow lesions, anything that have AV, arterial component in it. So even the infantile hemangiomas, the
Ultrasound.
high flow, yes, ultrasound, yes. Ultrasound will show high flow or low
Yeah.
flow. And then
Yeah.
even MRI will also show that.
Yes.
The thing about infantile hemangioma, infantile hemangioma, there will be high flow, but there will be a well-formed mass. Unlike
Yes.
AV malformation, where there's high flow and there's no mass per se,
Yeah.
unless if, yes. And then in lymphatic malformation, I talk about that you see fluid level in lymphatic
Okay.
malformation will not be seen in the others. But the others are low flow unless if they have an arterial component in
Component.
them. Mm.
Thank you.
And let's not forget our biopsy. Since that GLUT1, biopsy
Yeah.
and immunochemistry, yes. So we'll do that too. X-ray may show those phlebolytics in those that have the
Yeah.
venous
Venus.
malformation, yes. And then those that have herpes, Kaposi sarcoma, we need to do skin scrapings. Now that full blood count, by the time I
Mm.
presented this talk, the chief was saying, that cassava merit. It will also
Mm.
help us who has thrombocytopenia, because I just
Yeah.
mentioned the big ones and I know. So they said that formally, because of that cassava merit phenomenon, full blood count
Mm.
is a basic thing that should even be done for all, because that one is
Okay.
life threatening. Yes, so that platelet, we want to check the platelet count. Then the PCV, of course,
Mm.
may likely be low too. So we'll do clotting
Mm.
profile in case of those that have coagulopathy too. Thank you. So
But
those are,
I saw in the books that even when you do it and it's low, you
you
don't
should not,
transfuse platelet except you are operating.
yes, I saw that too. I saw that too.
Yes, the reason is that if you transfuse it, platelets go into the mass itself, so it makes the swelling larger
Okay.
or something like that. It's only when it's symptomatic or something. I
Okay.
think I saw something like that too.
Yes. Well done.
Okay, Chief, the only thing I wanted to add was that the X-ray too. You also do it for those syndromes that have overgrowth of the limb. I think you see skeletal involvement or something.
Yes.
You may see it on your X-rays. Yeah.
Yes.
And sorry, I don't know whether you mentioned about the timing. It's not all of them that will show in a newborn. So the patient may present just at birth. It may present in the infantile period. It may even present even when it has already started involuting or after the residuals.
Yes. Even in adolescent, we had a lady that came. I think she's 20 something years. 20 something years that presented with one of these vascular anomalies. I think it's hemangioma. But what was left was the residue.
Okay.
Mm.
Yes, Steph, as in these essentials, they gave different classification of what you'll be seeing, the different
Age.
these residual lesions that are present in some of the
Okay.
infantile hemangiomas. Like
Okay.
I think the commonest was telangiectasia.
Yeah.
then residual fibrofatty tissue, atrophic skin, then the list was skin excess.
Okay.
So the telangiectasia was 40%, the skin excess was 15%.
Okay. That's good.
There's something I'm trying to remember. There was one particular condition that they said you need to rule out whether it's this Weber before you go for surgery, or else the patient would have stroke or something like that. I can't remember which particular book I read it in.
So is it not the this thing? Is the Pekis now? Is it not the
I,
Pekis that has some seizure symptoms and all that? I think it's
me,
Pekis.
I didn't read Pecky, so, so in fact, it's as you spoke that I heard about Pekis.
Please, which one is Pekis again?
Is that one he said about perianal something something and plenty
Okay,
plenty
okay,
things there?
okay. No, he said that one is not
No,
pelvic
that is
syndrome.
pelvis.
Oh, it's different
Pelvis
from this
syndrome.
one. Sorry, which one is
Yes,
Pekis?
I had it somewhere. I have not seen it. Somebody said something like that. I didn't even ask him to explain further. I
Things are
just
just
carry
mopping
out.
up the stuff.
I say if I see am for textbook, I go read. I have not seen it now. I just said it.
Okay. If I see the list, I'll let you know. Let me just I'll be checking as the listen is going on.
Are you? Is it not phone you are using? Are you using tablet?
I'll check my tablet. It's in my tablet. It's not in my phone.
Okay, okay.
Mm.
Madam, let's progress so
It's
that we
time to
can meet
treat.
up.
It's time to treat the patient. Mm. I think after treatment will be complications of treatment, follow up and conclusion. Mm.
Okay.
Prognosis too. You can add that. Mm.
Treatment. Okay, let's start with hemangioma, especially the infantile hemangioma, which is the commonest. The first line drug these days is propranolol. Mechanism of action is anti-proliferative. It has this vasoconstrictive property and also have um, apothetic action, and then have anti-proliferative action also. Then the second line drug is corticosteroid. Then like the Kaposi form and all that, those ones are surgery. Most often is excision. Then the malformation, apart from the low flow malformation, apart from the high flow, the arteriovenous and all that, most of them, the first line of treatment is sclerotherapy, lymphatic, except in the lymphatic, you need to classify, is it the macro or micro? The micro ones, you cannot do sclerotherapy, but the micro type, some also argue that you need some level of sclerotherapy before you go for a excision. It gives you better control. Then for the arteriovenous fistula or arteriovenous malformation, you embolize and now go for a surgery, ligation. Then this okay, the Kaposiform hemangioma endothelioma, you and tuft angioma, vincristine and rapamycin are the two first line drugs you use for them. Um, Then I think this is general overview. Hello.
Yeah, we can hear you, Chief.
Okay. So the then form of treatment is also observation. Like the reach, you observe, it will involate. Then if there is a residual at the end, you can now offer surgery. Then if you have the segmental type of the port wine and other, some say you do serious excision, like the capillary malformation, like the port wine. You, if it's segmental, you can do serious excision, or you can do circular excision and now do port string, depending on the location where it is located. Then if it's not segmental, it's the smaller type, you can also do your sclerotherapy on them. Then there is also room for laser, the use of laser, especially the pulse dye laser, for the capillary malformations. I think it's the first line treatment for the capillary malformation also, the laser treatment. But some books are arguing it that currently that there's something they said about laser reoccurrence rate is high. So serious incision can also be done in those ones. I'm done now.
Okay. Chief, thank you for that. I just wanted to add from Grab and Smith, they
Okay.
just put that previously corticosteroids were first line management, but I don't know why they did not just put it that it is now second line. But I'll accept that it is second line. Then, yes, they said the more popular one now is propanolol
Yes.
for the first line treatment. So, but those that they mentioned for second line now involved what was that interferon 2 alpha, and I think
Interferon 2,
vincristine. Yes.
interferon 2 alpha and beta, both two, A and B can be used.
Okay, so the okay, no, the one they put here was interferon alpha 2A. That's what they put.
Okay.
So I'm looking at
They
it now.
didn't.
They
Okay.
didn't put
They
this
didn't
ahead.
add B.
No, they didn't. They
That,
didn't then they put vincristine. It could also be used. I think that's mainly when there is that hemanjo something. There's one particular
okay.
condition of the hemangioma that it will
Uh,
be resistant to all the other types apart from vincristine.
is the Kaposiform hemangioendothelioma.
Yes. I think that was it.
Vincristine is the first line drug.
Yes. Then which other thing now? Um, I can't. I can't remember the other thing I wanted to say. Oh. Okay, there was something we were talking about. We mentioned before. It's like we forgot when we were saying the stuff that you need to do embolization before you do surgery. That's
Okay,
a particular
okay.
condition.
Yeah.
Uh-huh. So to
That is AV
remember,
now. AVM.
yes. We are taking on now. That's why I was just saying it.
Okay.
Mm. Then what was the that thing again now? Okay, for the lymphatic malformations, they talked about using sclerosing agents. Okay, you mentioned that,
Sclerotherapy.
but yes. So them they gave examples of the sclerosing agent. ethanol, sodium tetradecyl sulfate,
Faith, yes.
doxycycline, and
And
doxycycline.
bleomycin. Bleomycin.
I think I
Okay,
saw that somewhere.
432. Okay, 432 is also used.
Okay. Okay. Then,
Uh,
in addition, those patients that have venous malformation, because as the chief Inu said that they usually have pain, low dose aspirin could be given to them for
okay.
pain relief in addition to
Uh,
sclerotherapy. Okay, here they gave options as observation, compression wrap, sclerotherapy, and excision for debulking. Then the
okay.
aspirin is also necessary for pain due to microthrombi.
Okay.
Yeah, I think those are the options. Yes. Thank you.
You're welcome, sir. Thank you for your contribution.
Thank you for the contributions. He has mentioned compression for the venous ones. We forgot to
Yes,
mention initially, yes. Thank you.
yes.
So the indications for surgery, I think so broadly that means the treatment options are non-operative, then
And
pharmacologic, then
yes,
operative. You understand? But
operative, yes.
non-operative, the infantile hemangioma that are not causing any that infantile or even the rapid, the rich. So those
Yes,
ones do non-operative. They said even some small lymphatic malformations can be observed. We use camouflage and all those. They've mentioned the medical therapy, and then we remember the apart from the drugs, sterilisant, compression, the operations now, the indications for surgery. So those lesions that are those ones non-responsive to the pharmacologic treatment, those ones that are in either cosmetically sensitive areas or those ones that are causing life-threatening conditions, especially those ones causing airway problems. So
obstruction.
yes, we have to list the indications for surgery. After that,
Yes.
we now mention. So the types of excision is either we are doing serial excision, lenticular excision, or the other is posturing you mentioned. So
Circular.
secular, yes.
Circular. Yeah, if you do circular incision, then you do pulse string to
Okay.
close it.
Yes, so that's just a summary of the treatment options. Thank you. So we'll go to
Okay. Sorry, Chief. Before we leave here, um, Grab and Smith actually gave an algorithm, so maybe we can check it later, as in for this
Okay.
treatment.
What edition?
And
8?
yes, the eighth edition, the last page after the conclusion. That's where it is.
okay, thank you.
Then they also mentioned, I think, topical timolol can be used for
Yes.
hemangiomas.
Okay.
Yes, small one.
Then yes, then for the steroids, intralesional steroids could also be used. That is to reduce the side effects of systemic. That is when you're going to your second line, or if there's any need to go to steroids. To minimize the risk of side effects, you can use intralesional steroids. Thank you.
Okay. Thank you. This propanolol has some side effects.
Yes.
Hypoglycemia.
Yes, yes. You're supposed to be looking out for hypotension and hypoglycemia or something like that.
We
Say
have
some
to check.
centers hospitalized for the first dose, I mean the first treatment.
Mm.
For
We,
observation.
yes, we
Yes.
forgot to even do ECG echo in our workup, especially some for those that have some cardiac problems. Okay.
Okay.
Thank you for those. So complications of treatment. The one of the other indication for surgery is for after the involuted phase, all those fibrofatty excesses may also be an indication for surgery. So the complications of treatment, then we can conclude. Prognosis, conclusion.
Complication of treatment is there now for side effects of the drugs, just like the propanolol that you talked about. Hypothyroidism, hypotension, uh,
Hypoglycemia.
hypoglycemia. Then your surgical wound can get infected. During surgery, they can bleed. Um,
Then maybe scar complications too.
yes, scar. Yes, they can give you scar, abnormal scar, especially when you use medical treatment like propranolol. Those ethesias that will remain, some of them can form abnormal scar. Then the sclerostrand, the sclerotherapy that we use, that's the sclerostrand that we use. Some of them will cause some abnormal scars that you need to revisit.
Okay, then for the surgery too, there could be risk of recurrence.
Yes.
Okay, thank
Okay.
you.
Then another important one for surgery that has to be mentioned is bleeding, primary hemorrhage.
Okay, thank you. You said primary hemorrhage. Yes, they
Yeah.
bleed a lot.
Mm.
These all those vessels were mentioned. Yes. Thank you. Prognosis and follow up. Prognosis and follow up. I will now do our post test.
Okay, the most important prognostic factor is the time of involution. I think I saw something like that. So the I can't remember the exact thing I saw again. No. I saw it in Essential. I've sent the book to two of you. I think it has delivered.
Okay,
Um,
thank you very much.
no problem, sir. You're welcome, sir. Um, I can't remember, but there was a section they did on prognosis. Of
Mm.
course, we can still maybe because of the old people, we can still mention this the 50, 60, 70 something, but
Percentages.
yes, but in essential now, they would, at the end of all of that, they'll say it overestimates it that now by between the ages of 3 and 4, everything is
Mm,
expected to have involuted.
Okay.
okay. You know that involution is one of the common MCQ question.
Okay.
Yes. Then before now, I think those old MCQ they used to talk about 5 years, 7 years, 4 years. I know the answer then is I think 5 years.
Okay. Okay.
Uh, so, but I don't know with what you are saying now. You are saying 3 to 4 years, huh?
Yes, let me
That,
just open it and say what they said. They said
okay,
traditional teaching of 50% by 5 years, 70% by 7 years, and 90%
uh,
by 9 years overestimates the duration of hemangioma involution.
okay,
Involution is typically complete between 3 and 4 years of age.
okay,
So
okay,
there's a section I now did on prognostic signs. It said neither the
okay,
size of hemangioma nor gender of patient influences the speed or completeness of resolution. Site of hemangioma has minimal effect on final results. Multiple hemangiomas do not necessarily resolve at the same time or speed. Presence of subcutaneous tumor element has no effect on final outcome. Early dramatic growth is not a prognostic sign of resolution. Time of involution is indicative of outcome. Presence of ulceration has no prognostic significance except for consequent scar.
okay.
So that's what they said. Thank you.
So at the end they ruled everything now.
Okay, yes. They just said
They ruled
the
that
time of involution is indicative of outcome. I actually thought they meant that it was one of the prognostic things.
Okay.
Then,
Thank you.
okay. They also said residual lesions are present in 69% of infantile hemangiomas.
Wow, that's large. That's a high number. So at this point, is either surgery or laser for those residual lesions will come off.
Yes, yes, yes.
Yeah, and
Thank
chief
you.
unit, that pyogenic granuloma, they
Mm,
also called it, in fact, it's like they said the proper name is lobular capillary hemangioma. They now
okay.
put often known as pyogenic granuloma.
Yes. In fact, they said that
Lobula.
it's a
Yes,
misnomer, right?
lobular capillary hemangioma.
It's
Or
a
say
misnomer.
because it is neither pyogenic nor a granuloma.
Yes.
That is the current name now.
Yes, so
Lobular capillary hemangioma.
Go tell the old teachers this one now. They go dey look you. You go
Oh,
dey there.
you
The
see, can you
man.
see the confusion in this name? You said lobular capillary hemangioma
So
because it's
what
like
what is
you understand. I thought we're having capillary malformation. Which one is capillary hemangioma again? Anyway, there's still some little. Anyway, thank you for this. Mm. Thank you. I'll stop recording now.